Hey, can you hear me? I don't think I can hear you.
Can you hear me?
Yes. Yeah. It's just a little echoey, but
Is it still echoing?
that's a little better. It's just like it's a little distorted, but it should be fine. I can still hear you.
Okay. It's
That's much better. Okay, that's
okay.
normal.
Okay, normal. Okay.
Yeah. Mhm.
I'll be a little bit closer.
Okay.
Okay, so that is up, ready to go. Wait. For joining us today. We will get started in just a few minutes. In the meantime, please feel free to introduce yourself in the chat. Just make sure you select everyone when you're using that chat function. We also have a slide up with some housekeeping items for things for you to remember. So your cameras and microphones are disabled, so please use that chat function for any questions, comments, or if you need any support. You can also use the Q&A function for any questions. We will have 10 to 15 minutes for question and answer at the end of the presentation. If you're participating today to receive CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate. And all participants who would like to receive credit will need to complete the evaluation survey after the session, which we will put in the chat for you and also send out via email afterwards as well. and all CME and CU certificates will be sent out via email by February 17th, along with a link to the recording for today's session, the slides, and a list of related resources. And all of those materials will also be uploaded to our website as well in the BHIPP training library. So again, we'll get started in just a few minutes. Thank you. Hello, how are you?
Hello, I'm good, I think.
Good.
I think it will go better if I run the slides myself.
Absolutely. Let's see if you can do it now.
Okay. Hi, Grace. Are you going to stick around?
I will be. Yes, I can help too.
I'll tell you guys I don't know if it's silly, a silly story. So Brianna loses her voice and I volunteer. Partly I volunteered because I had reviewed her slides a couple times. Okay. But I have a terrible voice that's getting worse. I only have one vocal cord that works.
Hmm.
The other's paralyzed, and the one that works doesn't close. So anyway, so I've asked to kind of stop giving presentations because of that.
Yeah.
So I'll
Yeah.
do my best. I'll get through this okay,
Yeah.
I think.
You're doing great so far.
Yeah.
So no worries.
Now, what do we do to load the slides here?
So you'll have to pull up the PowerPoint, and
And
once you have it up, you'll
wait a
pull
minute,
the
let me
PowerPoint up.
enlarge this.
Mm-hmm.
Now, share,
Yep.
Hmm.
Share on Zoom.
and here it is. Double click on that.
Yep. Your screen sharing, it's just loading.
There you go.
Yep.
And then we'll just have to go to slideshow so you can present in presenter.
So I should just hit slideshow, right?
Click
Hmm.
that, and then
Yep.
you might have to click one more button. That should pop up.
I mean, I clicked there, but nothing. Oh, there we go.
Oh, yeah.
And then you
Yeah,
can click from the beginning on the
from
left,
beginning. Yeah.
and that should, there you go.
It looks great.
Okay. Now, where's our audience? Are you guys the audience?
They're here, we just can't see them.
Oh, can they hear us? I hope not.
They can.
They can.
Oh,
That's
oh,
okay.
oh, okay. I didn't realize that.
No worries.
Wait
No
a minute. This
worries.
bar came up right in the middle of the slides. Can I move that down somehow?
Hopefully, you should be able to
No,
drag it.
it just went away.
Oh,
Okay.
That
okay.
was weird.
All right, good.
It came back.
Okay, good. All right. Well, we will
Well,
get started. Welcome, everyone, and thank you so much for joining us. My name is Elise Tabisky, and I'm the Outreach and Training Coordinator for BHIP, and I'll be introducing our presenter for today and facilitating the Q&A at the end of the session. For those of you that are unfamiliar with BHIP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals in addressing and managing the mental health concerns of their patients. And BHIP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. And the BHIP Warm Line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you. And it is my pleasure to introduce today's BHIP webinar, Medication Considerations in Patients with Autism Spectrum Disorder. And our presenter, Dr. Mark Riddle, who stepped in for Dr. Platt because she is unwell. So thank you so much, Dr. Riddle. And Dr. Riddle is a professor of psychiatry and pediatrics and the former director of the Division of Child and Adolescent Psychiatry at Johns Hopkins University School of Medicine. The focus of Dr. Riddle's research, teaching, and clinical practice is pediatric psychopharmacology. His current interests include dissemination of evidence-based child mental health interventions into primary care practices, and his recent publications include the book Pediatric Psychopharmacology for Primary Care, the fourth edition, published by the American Academy of Pediatrics. So we are very grateful to have you here today, Dr. Riddle. So thank you so much for sharing your expertise with us, and I will hand it over to you.
Well, thanks for that generous introduction. My hope is that this presentation will at least be better than today's weather. I can't guarantee that because I didn't make the slide set, so we'll have to struggle with it a little, probably here or there. But we're going to talk about medication considerations for patients with autism spectrum disorder. I don't have any conflicts of interest to disclose. Here are the 3 objectives. And this is a very busy slide, but I think you probably all know that there are sort of 2 parts, criteria A and criteria B at the left, for autism. And the first has to do with social, emotional reciprocity, nonverbal communication, reciprocal relationships. And the second has a number of different things: repetitive speech or movements or use of objects, adherence to routines or rituals, restricted intense interests, like memorizing the subway system in New York, as an example, unusual sensory interests or reactions. And there can be lots of other problems that we're going to talk about more. And at the far right, the little boxes at the bottom are the problems we usually get involved with: ADHD, anxiety, mood problems, etc. The other thing to say here is that when I was in training quite a few years ago, we were told autism affected 0.3% of the population. Today, it's 3%. That's a 10-fold increase. Okay, that would be like ADHD, which is about 10% going to 100%, 10-fold. So that there are many, many more young people and adults with milder symptoms that get this diagnosis. And some of those with milder symptoms don't qualify for all the services that those with more severe symptoms qualify for. And so many with milder symptoms may be leaning on you for help because they can't get it elsewhere. So I would just keep that in mind in terms of who might be looking for help. Now, here are the criteria laid out that we just talked about. This is criterion A with the reciprocal communication and interaction. And then criterion B with the stereotyped and repetitive behaviors, sameness and flexibility in routines, restricted fixating interests, and sensory sensitivities. I had one patient who needed to constantly flush the toilet. Okay, there was something about the sound of a flushing toilet that stimulated him sensorily. Now, treatment, and that's what we're going to focus on. So I'm sure you know there's no cure. And so we try to minimize the core deficits as much as possible and maximize independence as much as possible. And on the far right, this just shows you of the different kinds of problems, how different patients can present with a different spectrum or intensity of problems. Now, the problems that we're going to be working with are mostly the ones right at the top center. Anxiety, to the left irritability, to the right ADHD. A little less to the right mood, and I would have had sleep problems up there higher, I think, on the right in the green is sleep problems. The rest is probably going to be somebody else's to deal with and help the patient with. Now, some components of therapy. And here I want to start at the bottom, not the top. So we have medication in a box. That's what we're going to focus on. 2 above that is medical care, and there you see sleep, which in terms of anything beyond regular medical care may need to be a bigger focus. Above that, environmental interventions, usually skilled therapists take care of, and applied behavior analysis is a very specialized and effective therapy. But as you can see, clinicians need a specialized license, and they are mostly, as I noted before, taking care of the severely ill. And then on the right, other therapies, speech and language, occupational, physical, supported employment, social skills training. But that's obviously not the stuff you can be doing in a primary care office. And then school-based supports, and below that, family support. Now, if we think about medication, some rules of thumb. First of all, there's no efficacious medication to treat the core symptoms of autism. I'm sure you all know that. And there are plenty of negative studies. So we treat the symptoms of the comorbidities. Obviously, you'll rule out medical causes first, pain, constipation. And, there's no substitute for good therapy or environmental changes. Generally, you use lower doses, which we're going to talk about, and anticipate less predictable responses, particularly when the intellectual disability is more severe. This is just an example of avoiding a pharmacological intervention. So a 15-year-old who was nonverbal, had fairly severe autism, was admitted for aggressive behavior. Increasing escalation in behavior after a chair was moved out of his room. I was involved with working with a patient who had a very similar problem. This boy was standing on a chair so that he could draw on the ceiling, and he was totally preoccupied. So there was a discussion about giving him PRN medication. And before that, the team developed an instrument to try to allow him to safely draw. And he was able to adapt to that, didn't need to use the PRNs. Now, here are the indications we talked about before in those yellow and green colored slides. Severe aggressive outbursts, impulsivity, hyperactivity, ADHD, basically, repetitive behaviors, hard to treat with medicine, anxiety and irritability. Now, ADHD. So the key thing here is look at that 70%. So studies vary, but they all show 50 to 70% of individuals with autism have ADHD. So that can generally be treated and can make a big difference for someone who has that as a comorbid problem. Anxiety, up to 50% with one or more anxiety disorders. Easy to confuse core symptoms with symptoms of OCD, but most of this anxiety is not OCD, it's other anxiety disorders. Mood disorders, less, but still significant. Hard to sort out. Anytime we see irritability, we need to think about, could depressive symptoms be running along with that? And there's a higher rate of bipolar disorder in those with autism. and then sleep problems up to 80%. So it's really sleep and ADHD where we're going to have the most focus and where primary care is probably going to need to have the biggest impact than anxiety. Now, ADHD can exacerbate behavioral challenges, obviously. Stimulants. There's more research on methylphenidate than amphetamine preparations, so we generally recommend starting with methylphenidate. And it's clearly helpful for most patients. Possibly a somewhat weaker response, particularly the more severe the autism. Seems to have greater, well, that's what I just said, I guess, greater benefit in those with less intellectual impairment. Now, this dosage range is lower than I would have put in the slide. Generally, we think about methylphenidate up to 1 milligram per kilogram per day, generally without having to worry about much in the way of side effects. I've had patients as high as 2 milligrams per kilogram per day who needed that dose and didn't have side effects. So start low, but I guess one of the reasons I think the easiest medicine to prescribe for kids with autism is methylphenidate, because if you go too high and you get side effects, appetite starts to decrease. Sleep onset gets interfered with. You stop the medicine and that side effect will go away in a day or two. You're not stuck with it as you are with some drugs. If you're using Prozac, it can take a week or two for the levels to get down. So I generally keep moving a dose up till I get what I think is an optimal effect, and only back off if I'm running into side effects. Monitor for worsening repetitive behavior. That can happen. This is not mentioned here, but tics are a common side effect of stimulant treatment. That's a repetitive behavior, but there can be others. And you obviously monitor for appetite and sleep difficulties. And the long-acting preparations have been well studied. And remember, the longest-acting preparations, say, Concerta, only lasts for 12 hours, so it's gone quickly. Then alpha agonists. And here we're talking about guanfacine and clonidine. The FDA has now approved the combination of alpha agonists and stimulants. That's been true for several years. So if I get into trouble, say with methylphenidate, maybe instead of going to amphetamine, I just lower the dose a bit and add some guanfacine ER in Tuniv at bedtime, starting at 1 milligram per day for a week, then going up to 2, 3 if needed. And the maximum, and it's too bad this isn't on the slide, is 0.12 milligrams per kilogram per day. That's easy to remember, 0.12. We learned that way before we got to kindergarten. So that's an easy one to keep in mind with Intuniv. The main side effect is drowsiness. It's a 24-hour, the ER is a 24-hour guanfacine preparation. So you give it at bedtime, it helps with sleep onset, which a lot of kids with autism can benefit from. Occasionally decreased appetite or increased irritability, but with low enough doses, that generally doesn't happen. Atomoxetine. I'm not going to get into atomoxetine. I feel if you've gone through the 2 stimulants and the 2 alpha agonists, it's probably time to get BHIPP, or that should go to a specialist, a child psychiatrist, or a psych NP. But there's a little information about it. So our advice, this is just repeating, I think what I more or less what I just said. Now, anxiety. So the SSRIs are widely used to treat comorbid anxiety in ASD. Strong data supporting it, particularly in adults. Very few good trials in kids, but plenty of open label trials showing it can be useful, often at lower doses than usual. Side effects are the same, but kids with autism seem to be a little more sensitive. Worsening of irritability or agitation, more common. Now, here, I don't think this is in the slides, but if we look at the 3 SSRIs that we normally recommend, Prozac, sertraline, escitalopram or Lexapro. The most helpful for sleep is Lexapro, and it's generally the least agitating. So with these kids, I like to start with escitalopram Lexapro as my first choice, and sertraline as my second. Last, Prozac, fluoxetine. Dosing tips: start with low doses, titrate slowly. So what that would mean, say with escitalopram, let's see if this is on the next slide. No, it's not. It's too bad I don't have a slide for this, but with Lexapro or escitalopram, on a teenager, I'd start with 5 and go up by 5 milligrams each week up to 20. With a preteen, I might start with 2.5, 5, 7.5, 10, just half as much. The tablets can be broken in half, and there's liquid if it's really needed. But that's how I would think about the dosing. Weekly changes, 5, 10, 15, 20, or half that. Now, buspirone is mentioned here. Buspirone is a serotonergic partial agonist of the serotonin 1A receptor. There are 13 serotonin receptors in the brain. And SSRI has a direct or indirect effect on all of them. A lot of it's indirect. This buspirone is not nearly as effective, partly because it only affects one receptor, but it's unbelievably safe. And so sometimes, if the anxiety is really getting in the way or the irritability, while I'm waiting to get an SSRI dose up to the level I want, and then maybe wait several more weeks for it to have a good effect, I will also treat with a low dose of buspirone to just try to take the edge off the anxiety. And I usually use 10 milligrams in divided doses. And if this says 2, I use up to 3. And try not to go over 30 milligrams a day. So that can be effective while you're waiting for the SSRI to help. So our advice: start low, titrate slowly. To me, that means weekly changes unless you run into trouble. And look out for agitation, irritability, and insomnia. And switch to another SSRI. Okay, now what about repetitive behaviors? So earlier, at least mentioned, I think, that repetitive behaviors are hard to treat in any way, with medication or with therapy. It has been theorized that they were related to OCD symptoms because they're repetitive, stereotypic, but they appear to be mechanistically different. So the SSRIs don't separate from placebo for these repetitive behaviors in individuals with autism. And the side effects can obviously be a problem. There's some evidence that atypical antipsychotics can help, and we're going to talk about them. But obviously they have a higher side effect burden. So our advice is, if there's evidence that, hang on a minute, this is getting in the way of my screen. There we go. There's evident anxiety, you can target that with medications, but no evidence supports trying to directly address the behavioral symptoms, and the threshold for antipsychotics is high. Now, disruptive behavior and aggression usually starts with trying to understand the precipitant and then developing a behavioral therapy around it. And if it occurs in the context of anxiety, depression, hyperactivity, impulsivity, we've talked about treating that. But pain, learned prior rewards that a patient gets stuck on, sensory overload, trauma response, you'd have different strategies for each of those. And that goes again beyond the primary care office. That's got to be a good therapist working with the child and family. This is a schematic that just sort of lays out what we were talking about. If you can't find any other cause for or precipitant for the aggressive disruptive behavior, then you go to medication on the right. But if you can, you try to start, if possible, with a behavioral intervention. Now, severely disruptive behavior. So you probably know that the FDA, quite a long time ago, approved, quote, irritability in autism for risperidone down to age 5 and aripiprazole, Abilify, down to age 6. Now, irritability had a pretty complex definition because a rating scale was used that had many components. And that definition included severe temper tantrums, aggression, and self-injury, as well as symptoms of hyperactivity and real irritability. So it was a broad definition of problematic and usually disruptive behaviors. And in major clinical trials, the risperidone and aripiprazole also had helped, obviously, hyperactivity and very modest, very, very modest reductions in stereotypic behavior. However, you know the side effects are significant. And they're generally due to weight gain. The weight gain then leads to changes in cholesterol, etc., metabolic changes. And then there can also be sedation, particularly with risperidone and elevated prolactin levels. Usually at low doses in children, extrapyramidal symptoms don't occur. Aripiprazole has less an effect on weight gain and metabolic considerations, and it's less sedating. So we generally recommend these two, and if one doesn't work, try the other. We also recommend consulting with us, and sometimes we can't get a kiddo into the services they need. An example is for an autism evaluation at the Kennedy, the wait list used to be 6 months, then it moved to a year. Now we're hearing a year and a half from families that our pediatricians are seeing, that are calling us at BHIPP, help, what can we do? So you may get, in some ways, stuck doing this, and we will gladly walk you through it. We often get multiple follow-up phone calls on an individual child, and we encourage that if it helps. Now, specifically about the medicines. So aripiprazole, start with 1 milligram or 2 per day and go up to 5. And do it with weekly increments. And the target dose is usually 5 to 10. With an older adolescent, 15, risperidone, start with 1/4 of a milligram per day. Increase every 3 to 5 days to 1/2 milligram. Can dose twice a day. Here it says maximum usually about 4. I try to keep it down to 2 if possible, but sometimes we have to go higher. And you have to monitor, BMI, fasting glucose, lipids, liver function, etc. There is a, help me here, whoops, let me go back. Grace, help me here. This is this a BHIPP handout that's available about
Yes, I just placed that in the chat. Yeah, there's a link in the chat now, and they'll receive that afterwards.
And that's a 1-pager with, I think, everything you need to know.
Mm-hmm.
So our advice, you remember that the disruptive behavior is not a core symptom. It's a comorbidity. Try to figure out the cause and try to get the family and a good therapist to be involved in figuring out the cause. If it arises in the setting of hyperactive impulsive behavior, treat the ADHD. If anxiety is part of it or rigidity, try an SSRI, maybe start with buspirone with the SSRI. And I know we're talking here about you may have 2 or 3 medicines on board at the same time, but these are the safest medicines we have, and you're not going to do real damage to the child. If things get uncomfortable, you just lower the dose and the side effects should go away. If you want to consider starting risperidone or PIP, we recommend you reach out to us for consultation. Now, sleep probably should have been at the beginning, because if you remember, it was up to 80%. It's the most common. And here, again, we're probably going to need a good therapist working on this, because sleep hygiene, as you know, can be a lot of work. But with a child with autism, it can be a lot of work. There's a parent-facing toolkit. Will that also be in the Grace?
Yes, it will.
Okay, so that's for parents. Sleep hygiene requires incredible persistence. Probably the biggest thing to do is no naps. Naps will just destroy getting to sleep on time. And call us about this. We'll do what we can to help. And then consider melatonin, which is on the info sheet. Now, I may be overly conservative about melatonin, but the amount of melatonin that's needed to drive the circadian rhythm in the brain is about 1/10 of a milligram. And as you probably know, all these melatonin preparations on the market, what's on the bottle is not accurate. And there have been 2 well-done studies that show that there can be anywhere from 3 to 4 times more than the bottle says, or 3 to 4 times less. So we recommend, you'll see the 1, 2, 3, 4, 5th item down, USP certified brands. They cost a little bit more, not a whole lot more. I wish they came in 1 milligram, but they're only 3 and 5. So we recommend the 3 milligram USP certified brand. Brianna says here, time-limited trial 3 months. My reading of the literature and what the neuroendocrinologists say is limited to 1 month. Now, my take is that a large proportion of kids on melatonin are on melatonin. Yeah, I don't know how many, 50%, 40, or 30, but a lot. And the parents swear by it. And the doses are often way too high. What people don't recognize is the main side effect of melatonin is sedation. And I think what they're doing is they're sedating the kids, and destroying is too strong a word, but they are completely blocking their circadian rhythm. So this is not how I would address sleep beyond a month. And it's not easy to try to talk your families out of it. And again, consider treating anxiety, the ADHD, mood comorbidity, anything else that may secondarily help sleep, as would, say, Lexapro at bedtime for anxiety. And that's it.
Great. Thank you so much for that wonderful presentation, Dr. Riddle. We are going to move into our Q&A portion of the session, so please feel free to place your questions in the chat or use the Q&A function as well. As you were going, Dr. Riddle, we had a few questions pop up. So the first one was when you were talking about comorbid ASD and ADHD and medications, and a provider put in, my patient has seizures. What would be helpful for ADHD there, I believe?
Probably stay away from the stimulants and use the alpha-2 agonists. So Intuitive, brand name for the ER version of why am I blocking here? But anyway, the Intuitive at bedtime, starting at 1 milligram, increasing weekly by 1 milligram, up to 0.12 milligrams per kilogram max. And that has about 60% of the effectiveness of a stimulant. It's not quite as powerful. If that doesn't work, give us a call and we can get more exotic. But I think that's for sure what I would try first.
Yeah.
Can you just check back, Grace, and make sure that's an adequate response?
Yeah. Please let us know if that answers your question, and if not, feel free to follow up with that in the chat. Next question.
Grace, on that, you, Lily.
No, it's okay. Next question we have is, in nonverbal patients or patients with greatly limited verbal skills, it's hard to sort out if they're agitated, irritable, sad, anxious, or hyperactive, or some combination of any of that above. How do you think about sorting out this challenge to decide which medication to start?
So I guess the first would look for anything that seems to trigger or make this symptom worse, which might be something that looks like anxiety. It's a situation that might make any child a little anxious, but it makes this patient very anxious. Does it? Well, I guess that's what I would mostly do. I think that if I wasn't sure what it was, I would start with Lexapro because it's approved for depression and anxiety in youngsters. And I would treat with it. If it helped, then you're helping maybe mood, maybe anxiety, maybe both. If it didn't help, then, well, I guess I don't remember if ADHD was in the picture, but you can usually see impulsivity and hyperactivity and treat that. The other thing I would do is make a videotape, show it to a colleague, anything you can to just get some other opinions. Now, I don't feel like that's an adequate response, but I don't know.
You guys you let us know if that answers your question. We actually had a follow-up from the first question, asking about ADHD with seizures. They said, how about Strattera?
Strattera's okay, but I would not go there first. I would go to the alpha agonist first.
We also had a comment in that KKI has a program to educate and train primary care physicians to diagnose ADHD, and that you can contact Vandana. She put her email in the chat if you're interested in learning more about that. We had another.
Just a comment
Yeah.
that I have heard that that's a very good training program. Now that's much more intensive than what we're doing here. But I think the people running that program are excellent.
Another question for you is, what is the maximum dose of Respirol I should try before switching to Abilify?
I wouldn't go over 4. You know, our adult colleagues who treat psychosis on the inpatient unit will go to 8. But in my discussions with them, we've kind of decided on 4 seems like a reasonable place. And if that's not working, try something else. And there are other antipsychotics. Obviously, these are just the 2 that have the FDA indications.
Next question we have is, when you say do a time-limited trial of melatonin for 1 month, do you mean stop it after 1 month as a circadian rhythm should now be restored, or stop it if no benefit after 1 month?
I would stop it after 1 month, whether it helped or not, because again, I'm not an expert on this, although I have read some of the literature from the neuroendocrinologists, and they just think it's not wise to block the circadian rhythm in a child for an extended period of time. You know, there's no way to study that exactly, but they're very, very, very cautious about that. And if it were me who could make the decision, I would find other ways to try to treat the sleep problem other than melatonin.
Um,
And I don't think I'm going to make any friends that way, but it's what it is.
okay. I reshared the email for the KKI program in the chat, also in the Q&A. Please let me know if you don't see that. And if you have any other questions, we still have time for more, so feel free to put them in the chat or in the Q&A. As a reminder, we will be sending the full recording of today's session, the slides, and a list of all the related resources to you guys afterwards, and it will also be uploaded to our website early next week, so you'll have all of those resources. But if you have any other questions, please feel free to put them in the chat or the Q&A function.
Everybody gone?
Mhm. Any other questions? Oh, have a question. What type of information from schools is helpful to have for medication management?
Most teachers are very good at assessing attention, impulsivity, hyperactivity, because they have seen so much treated and untreated ADHD that they're really aces at that. They're obviously going to be good too with sleepiness, but that one's pretty easy. But I'd say mostly the ADHD stuff. Now, if a child gets stuck in any kind of routine, they're going to pick that up. So I think they can be helpful to you in a lot of ways. And I guess anxiety, if there is something that provokes it.
Any other questions? Give it another minute or two. Feel free to place them in the chat. We also place the evaluation survey in the chat for you guys as well. And if you'd like to receive CME or CEU credits, you'll need to complete that survey. We'll also send the survey link to you out via email as well after the session, so you will have that. But it's in the chat. Okay. It looks like we don't have any more questions. So thank you again for this wonderful presentation, Dr. Riddle, and to all of our participants in today's session. Again, the slides and Alyssa-related resources and the recording for today's session will be available on our website next week in our training library. We will send CME and CEU certificates to participants by February 17th. Please remember to take that evaluation survey. Stay tuned for our future BHIPP trainings by following us on social media, and also we'll send them out in our email campaigns. And thank you all so much again, and I hope everyone has a great rest of their day. So thank you. Oh, getting a lot of thank yous, Dr. Riddle, in the chat. Very helpful, very useful. Okay.